So, ladies and gentlemen, we're moving into our next session, which is managing hair loss in GP clinics. Please put your hands together and welcome on stage Dr. Ali.
Hi, good morning everyone. Thanks for the very kind introduction and thanks for having me here this morning. So after you have solved issues with getting the penis erected, some people want to have some bulu on the side there. So if you want to assist them in their hair loss, this is one of the ways you can look into. I'm just kidding, we're not doing that. So basically, I'm here to assist you in managing hair loss in your GP setting. How many of you actually see patients with hair loss? Quite a number, right? And how's the management? Yay, nay, so-so, not sure what to do. I would say you probably face some challenges at the end of the day. Let me see if I can help make it easier for you and help me to get any kind of challenges. If you've got questions, please shoot, and I'll answer as much as I can. Right, so hair loss is actually very important. Why is it important? Because a lot of times when people talk about hair loss, they think it is a salon problem, they think it's a beauty problem, they think it's a magazine problem, they think it's a TikTok problem. However, hair loss is alopecia. Alopecia is a medical condition. A medical condition should be treated by a doctor. Right. So because of that, the onus is on primary healthcare to actually start to identify and to start doing treatments that move them towards the direction of some result. Even if you don't get full results yet, you need to build the confidence of some result. Because if you don't, then they'll say, Dokter, aku ni tidak tahu pasal hair loss ni. So since my doctor can't treat, I'm going to go somewhere else. I'm going to find products on Watson's, Guardian. I'll find something on TikTok and try to do, I'll get oils, rosemary and dump it on my head, which may or may not work, right? So hair loss, 50% of men, by the time they hit 50, right, already have some hair loss. And for women, by the time they're 70, about 50% of the women population also have hair loss. Men, unfortunately, when you're born as a man, you come out and see, oh, it's a boy, condemned. 1 in 5 hair loss already, confirmed. And that's not including whether the father has yet. And if there's someone in the family who has hair loss, his chances goes up by 50%. So you see, it's a very large population of people that you need to treat, and it comes back. Primary healthcare, what are we doing about it? Okay, slides are horribly small, so I didn't expect it to be so small, but you get the slides later. So I'm just going to classify just a few simple ones, especially the ones that you're going to be seeing. Number 1, androgenic alopecia. So the term androgenic alopecia, people think androgen alopecia means male pattern hair loss. That is not true. It can also be female type of androgenic alopecia. Okay, scratch it a bit, maybe we'll explain that later. Alright, next, alopecia areata. All the 20-cent coin, 50-cent coin, and today the coins look the same, so whatever it is, circular, patchy hair loss. Next, telogen effluvium. After pregnancy, after COVID, after vaccination, after dengue, after any kind of illness, after stress, after a breakup, after losing your job, telogen effluvium. This can happen. Right? And there are some significant differences. Okay? So I'll just give you a very quick, broad category how to tell the difference. With androgenic alopecia, it's usually a pattern. So for men, there's the downward scale. Front, M, half, like a Bruce Willis, then you go higher, like a Jason Statham, then you go backwards and backwards and backwards. Alright, so you've got your node 1, 2, 3, 4, 5, 6, 7. Okay? For female androgenic alopecia, it is typically a Christmas tree type of pattern. What in the world is a Christmas tree type of pattern, right? So when you look down on the patient, right, at the parting line, the hair loss is got a Christmas tree kind of pattern. It's jagged. It's jagged. It's not circular. It's jagged. Okay, it can be small, thin Christmas tree. It can be a medium Christmas tree. It can be a fat Christmas tree. But that's what it means. Androgenic alopecia. That itself already tells you. Androgenic alopecia. Now you need to think. Androgenic alopecia means somewhere along the way elevated testosterone. Somewhere. So for men, it's the DHT being too sensitive. For the female, it can be 2. 1, they've got something producing more androgens. Second one, it can be because estrogen is decreasing. Alright, so typically you will see a lot of androgenic alopecia in women from the age of mid-40s onwards. Prior to that, okay, healthy hair. Mid-40s start to have some, by the time they hit perimenopausal, quite significant. And you need to catch them early because you've got very good outcomes of treatment later. Okay? And typically when they come, if you pull their hair, they're actually okay when there's nothing, no hair loss. Telogen effluvium, on the other hand, if you pull the hair, they start to fall. So be very gentle. Okay? So one test to do when you see a patient, do what is known as a pull test. Who knows what's a pull test? Right? Because you're not it, but you don't know what it is. Never mind, let me tell you. A pull test, basically, go to any location. So I like to start from the back because it's a bit safer. You go to the back and then you just pull one tuft of hair, you pull 1, 2, 3, 4, 5 times you pull. Okay? Don't pull too hard, but it must be firm. Pull and let it slide along your fingers. Within that 5 pulls, how many hairs come out? If more than 7 hairs, that's a positive pull test. Means it's in very active shedding phase, which means it is highly likely to be a telogen effluvium patient. Alright? Now having said such, Dr. Ali said pull 5 times. If you pull the first time 10 hair come out, please stop. Please don't pull 5 times and say, oh, Dr. Ali said 5 must pull 5, or 100 hairs come out. He said so. Please stop. The first pull, 7 hairs up, please stop already. Okay? So you do the back, the top, the front. At any point, at the same spot, when you pull 5, more than 7 hairs is out, that's a positive for your telogen effluvium. Then you're not looking at other things, you're looking at just treating telogen effluvium. Right? So that's how you do the broad category of differentiation. So small. Good. Now, the rest not so important. The rest here is actually scarring alopecia. Okay, so if your patient has a previous scar, burns, chemical burns, or injury, then they've got alopecia, then that's a separate story altogether. That one, very difficult to treat. So the first ones are the ones you're looking at. Okay, so here is the diagnostic ones. Okay, later we're going to dermoscopy. So I've already covered androgen alopecia. Alopecia areata are the ones that you also see quite commonly. Your circular, patchy hair loss. Now there's a rule of third for alopecia areata. The rule of third is with steroid treatment or even sometimes naturally, there is 3 types of outcome. 1/3 would recover fully. 1/3 would recover with partial hair and 1/3 would have no recovery at all. You must have this knowledge at hand because it's important to counsel your patient to let them know the outcome of alopecia areata is today we start treatment with steroids or whatever we're starting you with. This is the outcome. 1/3 yes, full recovery, 1/3 mid recovery, 1/3 no recovery. Okay, and if there's no recovery after 2 years, same spot, then go do a hair transplant. But you can only do a transplant on an alopecia areata spot if it's considered stable, no new spots, last 2 years, and no recovery at all. That kind of shows the body is not going to be reacting, so the chance of it reacting is much lower. Okay? Telogen effluvium, alright, I already talked about the pull test and scarring condition. Okay, so when we talk about dermoscopy, so dermoscopy will sound very chunky and sound very expensive. Don't worry, don't buy anything expensive, especially if you're just in your GP setting. What can you use? Use your phone. But just go buy the attachment. You go on Temu, Shopee, Lazada, you look for those lens, the macro lens. Okay, you take the macro lens, you put it onto your patient's skin, and you snap a photo. At the end of the day, you're not dermatologists, all right? And we're not going. I'm not going to bring you to that level either. We're going to do basic diagnostics. Basic diagnostics. Okay. So with androgenic alopecia, again not very clear, but it's all right. So with androgenic alopecia, generally you would see hair shafts. The hair shaft from the skin all the way to the distal portion. They are the same size. Okay? Uniform size, but there will be thick ones and thin ones. Okay? There'll be thick hairs, thin hairs, thick hairs, thin hairs. But the cylinder is the same throughout. Same only the batang. Right? That is one of the signs of androgenic alopecia. If it's late androgenic alopecia, where there's already hair loss, you can even see dots whereby the follicles have already closed up. Okay? Next, if you're talking about telogen effluvium, so for telogen effluvium, there will be short non-villous hair. Here, C. Okay. Alright? Not very clear, but never mind. There will be short villous hairs coming up. The rest of the hairs are actually okay. So telogen effluvium same. Telogen effluvium is a certain shock in your system whereby you're having certain hair loss. So the hairs have no time to shrink in size. So you're actually having quite uniform amount of same type of hair, but given to all these tiny small ones that's popping up, because the old ones have fallen out prematurely, new ones are trying to regrow themselves. So you will see everything is thick forest and then these tiny bushes of thin hairs starting to pop up. Androgenic alopecia, got thick tree trunks, thin tree trunks mixture. Next is alopecia areata. So alopecia areata, on the other hand, is a bit weird. The one that is nearer to the skin is very narrow. Your hair that's more distal is fatter. So it looks like an exclamation mark. Fat and thin legs. Right? So that's what it means by an exclamation mark sign. So there is something going on down there. The production of your keratin is very bad, and sooner or later it's going to stop. So that's also another telltale sign. Okay? So you can get the slides from me later. And finally, if it's scarring alopecia, you look in, you zoom in, there's nothing. No follicles, no dots, no follicle opening, just plain flat skin, that's a scarring alopecia. No chance of growth with PRP or finasteride or minoxidil or whatever. Okay? So I've cleared for you. Sorry, you have to take a photo? Okay, take. Okay? So I've cleared for you that. What are the other things that you can do? Of course, you can do a general blood test. You're going to find out their thyroid profile, you're going to find out their full blood count, you're going to see their iron studies, you're going to see the hormonal profile, T3. These are also important. And now there's new things which are genetic testing. So genetic testing is not so much about finding out are you going to have hair loss or not. The genetic testing is more to find out what does the body respond best to. Okay? Please note there's a difference. We're not here to find out are you going to have hair loss or not, but which one you respond best to. Why is this important? Because as doctors, we practice medicine. We keep practicing. We give first, then we adjust later. We give first, we adjust later. And sometimes your patient doesn't like it. You know why? Because hair is not like flu. With flu, 2 days, 3 days, you're cured. With hair, it's 4 months, 6 months, convincing the person to continuously take this medication and let's see if there's result. And if there's no result, we'll give you something new and let's wait another 4 to 6 months. Hence, a lot of dropout. A lot of patients will find malas to follow you. Because the ones in the advertisement says guarantee 2 weeks grow hair. Okay? So genetic test is important. And finally, if you find it very difficult, you can do a scalp biopsy and send it for histopath. This is actually an example of how a genetic test looks like, the results. Okay? So when you see, at the end of the day, this patient has a 67% response rate to minoxidil, 86% response rate to finasteride, no response to caffeine, low percentage or no response to dutasteride. Over here, no response to biotin, responsive to vitamin D, B12, and tretinoin, and zinc. So you see, it's very individualized. You stop doing standard treatment for your patient who requires 4 to 6 months of their time and investment with you to show results. So you're basically trying to cut down this gap of confidence. They are only confident with you if you, within the first round of treatment of 4 to 6 months, show them the best result or some positive result. And not what we typically do. What we do? Adjust and say, oh, maybe not suitable for you. Let's try another one. And let's try another one. Okay? So be very specific.